Hi there, my name is Dr. Kayla Sims. I'm a fourth year psychiatry resident based out of McMaster University's Waterloo Regional Campus. It is my pleasure to talk about the mental status examination for psychiatric assessments. The mental status examination is its own physical examination for psychiatry. Unlike other physical examinations, there's no deliberate time set aside for the mental status examination. And the art of the assessment is learning how to do it at the same time that you're completing a psychiatric interview. Today, I'm going to go through a stepwise approach to completing a mental status examination. And I encourage you to develop your own stepwise approach that works for you based on the rotation that you're completing in psychiatry. What's useful about the mental status examination is that we do expect it to be dynamic and change over time. So for example, a patient being admitted to hospital will not have the same mental status examination as when they're being discharged. And we use this mental status examination as a marker for patient improvement or deterioration. The mental status examination has many components, and it's pretty common to have an acronym developed to anchor the examination. For myself, I use an acronym called ABC Septic. I like this acronym because I find it moves from things that are more external and observable to things that are a little bit more higher order in the examination. And I'm going to take you through my basic approach to a mental status examination today. The first thing that I like to comment on in a mental status exam is appearance. This is an element of the exam that is observed. This is where you could comment on the patient's age, their apparent age versus their chronological age. Does this patient look their stated age? This is where you can comment on a patient's grooming. Do they appear unkempt, disheveled, well-groomed, or immaculate? This is also where you can comment on a patient's dress or clothing. Are they appropriately dressed? Are they overdressed? Or are they underdressed? This is also where you might want to comment on identifying marks such as tattoos, lacerations, or scars. The next observable aspect of the mental status examination is behavior. This is where you can comment on a patient's eye contact. Is it poor? Is it fair? Is it good? Is it piercing? Is it guarded? Is it inconsistent? You might also want to comment on a patient's pupils, such as in keeping with a toxidrome, like pupils that are constricted or dilated. You may also want to comment on a patient's posture. Are they slumped? Are they erect? What does this sort of tell you about the way the patient may be thinking or feeling? You also might want to comment here about adventitious movements, such as hypoactive movement, like psychomotor slowing, where a patient exhibits decreased activity, they're slow to respond to the environment, or they appear sluggish. You may also want to comment on if a patient has hyperactive movement, like psychomotor agitation, this compelling need to be in constant motion or difficulty sitting still. They may even exhibit elements of agitation, such as severe anxiety or irritation, or excessive motor restlessness, such as pacing or hyperventilation. You can also comment here on if the patient appears catatonic, if there's any stereotypical movements, or tics or tremors. The next area of comment is cooperation. Again, this is an observable assessment. This is where you might want to comment on the patient's general attitude towards the interviewer. Were they cooperative? Was there a passive aggressive style of relating to the interviewer? Were they rolling their eyes? Were they speaking in an imitating vocal tone, mocking the interviewer? Did they appear defensive? Did they appear dismissive? Were they guarded, such as being overly careful about sharing information with the interviewer? Were they closed? Were they secretive? Was there infrequent self-disclosure, or were they spontaneous in their narrative account? Was there a sense of oppositionality or defiance? Or were they highly suggestible? Next, you comment on speech. Speech, again, is observed. The key with speech is that some people often confuse speech for thought form. Speech is the manner of which we speak, and it involves things like the rate, like words per second, rhythm, latency, prosody, articulation, fluency, volume. Thought form or thought process is a comment on someone's thinking, and it is a sign of whether they are organized or disorganized. And so that would be commented on later on in the assessment. But for the purposes of speech, we're concerned with the mechanics of speech. Emotion. Emotion is both inquired and observed. Emotion consists of two parts, a patient's mood and a patient's affect. A patient's mood is their internal subjective state, and it is often what the patient describes. For example, you can ask a patient, on a scale of 1 to 10, 1 being the worst mood you've ever had, depressed, low, tearful, and 10 being feeling good, feeling like yourself, where would you rate your mood today? In your mental stats examination, you might want to include this number as a determination of the patient's mood. But it's also helpful to put something in quotes like angry, sad, depressed, happy, elated. The second part of emotion is affect. This is observed, and it is the external manifestation of a patient's emotional state. In other words, how the patient presents. There are 5 elements of affect. The first is the quality of the affect. Do they present in a dysphoric state, a euthymic state, or a euphoric state? Next is congruence. This is where you comment on whether the affect is congruent to the mood that the patient has stated. In other words, the affect can be incongruent to the mood or congruent to the mood. So if the mood and affect are congruent to one another, this means that the patient's affect is appropriate as an emotional expression to the described mood. If the affect is incongruent to the mood, this means it's an inappropriate emotional expression to the described mood. For example, a patient crying while telling you that they're happy. The next aspect of affect is range. This is where you comment on the patient's ability to experience a range of affect. Is it flat? Is it blunted? Or is it broad? For myself, I like to think of turning a knob of a volume. If I turn it down, I consider this blunted. If I were to turn the volume off, I consider this flat. And if a patient can show me a broad array of affect, then I consider this to be quite broad. The next is reactivity. Reactivity is related to the content that the patient is expressing. So if the patient is talking about something particularly difficult, it makes sense that they would cry or demonstrate a more dysphoric affect. If the patient is talking about something happy, then we would expect them to demonstrate a more content or euthymic affect. Reactivity can be restricted in that the patient's affect does not change regardless of what they're talking about, or it can be appropriately reactive to content or full. The next is the affect stability. This is where we would talk about lability, like a capricious, unstable, quickly changing affect, which we commonly see in mania. If an affect is stable, it doesn't mean that it's the same throughout the entire time we're interviewing someone, but it doesn't represent lability. The next aspect of the mental stats examination is perception, and this is inquired. Perception consists of sensory perceptual disturbances, like hallucinations. The most common are auditory. Less common, though relevant hallucinations include visual hallucinations, olfactory hallucinations, gustatory hallucinations, and tactile hallucinations, or somatic hallucinations. If a patient endorses sensory perceptual disturbances, we may want to learn a little bit more about what's going on. For example, if they are hearing voices, we might want to know the number of voices, the type of voice. Is this commenting, conversing, or command hallucinations? Are they in the third person, such as they're talking about the patient, or the second person, such as talking directly to the patient? And how intrusive are they? We also want to comment on if the patient is experiencing sensory perceptual disturbances during our interview, in which case we kind of look for whether the patient is responding to internal stimuli. Another perceptual disturbance includes dissociation, such as distortions of the patient's reality, either in the presence of sensory or external stimuli. This includes derealization, a feeling of unreality, detachment from environment, dreamlike atmosphere, or depersonalization, where the patient experiences their own body as having changed, or being detached, or standing outside and watching oneself. This is very common in trauma and can happen if the patient feels a sense of re-traumatization. The next part of the mental status examination is thought content and thought form. And I underscore these under the umbrella term thought. This is both observed and inquired. Beginning with thought content is what the patient says, the topics, the ideas, the issues that come up. The main thing we want to capture in thought content is suicidal and homicidal thoughts. Does the patient express suicidal or homicidal ideation, intent, plans, means, or acts of furtherance? Other things that might come up in thought content include delusional themes or fixed, firmly held beliefs that are outside the realm of realistic possibility, as well as obsessions, preoccupations, ruminations, overvalued ideas, paranoia, suspicion, thought insertion, thought control, thought broadcasting, or thought withdrawal. These are complex concepts, and I would suggest that if it comes up in an interview, that you ask your supervisor to give you a little bit more briefing on what these concepts mean and how to differentiate them. Thought form involves an assessment of the patient's thinking. We are often looking for the patient's thought organization. However, it's difficult to get a sense of someone's thought disorganization or organization. So we generally use this based on speech, particularly the goal-directedness and logic of thought. Again, not the mechanics of the speech that the patient is presenting, but the ideas and how they are linked together. When discussing thought organization, we can think about whether the thinking is logical, as in organized, coherent, clear, direct connections between content, and one idea flows directly into another. Or we can move it along a spectrum all the way to word salad. So from logical, the next stop would be circumferential, digressions to unnecessary details in thought and speech before communicating the central idea. This is similar to taking a ride on a carousel. You'll get back to the beginning of where you started, but you're going to go for a bit of a ride before you get there. The next step is tangential. This is oblique, digressive, and sometimes irrelevant to the central idea. This is similar to a train leaving the station, where we might not get back to the original platform. Next is loose associations, which is often described as severe disorganization. This is where little or vague connection is made between concepts. It can kind of feel like a continuous tangential rabbit holing, where it moves conversations further and further away from the central idea. And finally, word salad, where there is no obvious connection from one word to the next. Next in the mental stats examination is insight and judgment. This is inquired and is a difficult concept to highlight in the mental status examination. Insight is a patient's awareness shown by their insight into the nature of their difficulties. Judgment describes a patient's decisions or actions. Insight can be poor, fair, good, or intact. Judgment can also be poor, fair, good, or intact. For example, if a patient has insight, they have awareness of their physical and mental limitations. They understand the nature of their illness. They understand the consequences of accepting treatment, or refusing treatment. And they recognize the need for coming into the hospital. An example of a patient's appropriate judgment would be appropriate responses to the situation around them. Maybe the patient brought themselves to the hospital, or maybe a patient understands, even though they didn't bring themselves to the hospital, they want to be admitted because they feel like they're no longer in control of their behaviors. Some ways to inquire about insight and judgment are largely by asking questions around consent and capacity. For example, what do you think is going on? What do you think would be helpful? What is your understanding of what these medications are for? What would happen if you stop the medications? How long will you have to take these medications for? What, if any, role may substance use play? What impact has your illness had on you, your life, your functioning, or your relationships? This highlights one of the examples of how the mental status examination is not a set aside time in our psychiatric assessment, but rather interwoven throughout the psychiatric assessment. And finally, cognition. Cognition is both observed and inquired, and involves the capacity to process, organize, and understand information. The most basic tenet of cognition is someone's level of consciousness. Are they alert and oriented to person, place, and time? Formal testing of cognition is often done in a geriatric setting. For example, the MoCA or the MMSE might specifically test a patient's perceptual motor skills, attention, language, memory, executive functioning, or spatial awareness. Most often in psychiatry, particularly in the emergency department, we might not formally test someone's cognition, but we can comment on whether there is disturbance in sensorium, attention, alertness, arousal, or orientation, such as if the patient is intoxicated, lethargic, or comatose. That concludes the mental status examination in a stepwise manner. I'll now take you through an example of an unremarkable mental status examination. On examination, Mr. X presents as a well-groomed Caucasian male. He is dressed appropriately in personal clothing and appears his stated age. He is able to appropriately engage in the assessment and maintains good eye contact overall. No psychomotor agitation or slowing was apparent throughout the assessment. His speech is of normal rate, volume, tone, latency, prosody, articulation, fluency, and spontaneity. He describes his mood as happy. His affect is congruent and demonstrates normal reactivity, broad range, and is generally euthymic overall. Mr. X denies current sensory perceptual disturbances, including visual, auditory, tactile, gustatory, olfactory, or command hallucinations. There is no evidence of internal preoccupations or response to internal stimuli throughout the assessment. Thought form is generally goal-directed without evident loosening of associations or flight of ideas. Thought form is generally organized to circumferential. Thought content does not reveal current suicidal or homicidal ideation, plans, means, intent, or acts of furtherance. Mr. X is readily and reasonably able to assure his safety within this facility, as well as his ability to appropriately inform staff of worsening symptoms, including dangerous to self or others. There is no evidence of delusional thought content on assessment today. Insight appears good overall, and judgment appears fair to good. His attention and concentration are grossly intact. Mr. X appears alert and oriented to person, place, time, and recent events. And that's a brief overview of the mental status examination. I hope it was helpful.